Good evening, everybody. Apologies if this is not a perfect presentation. I think we're all getting used to the new normal, which is not meeting in person. And so we will do our very best. And it's obviously difficult that we can't hear your interaction at the time, but we'll have time for questions after. So a little bit of background about myself, I suppose. I'm an interventional cardiologist, an adult structural cardiologist. I did my cardiology training here in Sydney and then moved over to London where I was a fellow and then spent 3 years there as a cardiologist before coming back. And I've been in Sydney at St Vincent's for the last 7 years. Today we're going to be talking about aortic stenosis, and the learning outcomes for this really are that we're going to discuss the etiology and the prognosis of aortic stenosis and aortic valve disease. We're going to outline the diagnostic modalities and management options for patient with aortic stenosis and describe the strategies for treating severe aortic stenosis, including medical management, surgical aortic valve replacement, and transcatheter valve implantation, or TAVI. We're going to outline the best way to manage these patients in terms of imaging and specialist referral, and then anything else we want to discuss. So there's two parts to the talk. The first is a few slides just describing aortic valve disease, and then we'll get into some case studies in a bit more detail. Here's an example of a typical patient. He's 80 years old. He's got exertional dyspnea. He has no chest pain. He's got an ejection systolic murmur with some left ventricular hypertrophy on his ECG. He's got a number of comorbidities, including previous COPD, a TIA, some hypertension, but no known coronary artery disease, and he's got some renal impairment. That's one to think about. That was a pretend case. This is a real case. An aortic stenosis happens to all people, even celebrities. This is a 75-year-old man who's got a previous history of drug use. He's been married twice, and he's had a loud ejection systolic murmur, which was heard by his GP, despite being able to jump around and do this on a stage. So we might just talk about aortic stenosis in general. It's a very prevalent disease. In fact, 1 in 8 people over the age of 75 are affected by aortic stenosis.
In a healthy heart, blood flows freely from the left ventricle through the aortic valve to the aorta. However, during aortic stenosis, aortic valve leaflets experience calcification, lipid deposition, and inflammatory infiltration. The severity of aortic stenosis relates to the stiffness of these leaflets, which increases over time, forcing the heart to pump harder.
And excuse me if that was a little basic, but that's really just an introduction to what we're talking about. There are some stages of aortic stenosis going from a normal valve to mildly restricted to moderately restricted, where we get a bit more calcification and restriction of the leaflets, to severe aortic stenosis, where the leaflets really don't move at all and there's severe obstruction to the blood flow into the aorta. Aortic stenosis is actually a devastating condition on the left ventricle itself. The increased afterload causes a supply-demand ischemia. There's mechanical stress, there's myofibroblast infiltration, and what actually happens is that the myocardium becomes diffusely fibrosed, and eventually this actually causes weakening of the heart muscle. And by the time that the heart muscle has become weak, patients tend to get very sick very quickly. So initially the patients have a normal heart, of course, but once the aortic stenosis ensues, the left ventricle becomes damaged. That in turn leads to increasing pressure in the left atrium with or without mitral regurgitation. With that then comes increased pulmonary artery pressures and dilatation of the pulmonary arteries, and then eventually right ventricular failure and pulmonary hypertension, and this is really end stage. Unfortunately, the way that time course ensues is unpredictable and can be variable, and by the time some patients get symptoms, they've already developed changes, irreversible changes in the heart, that even if we fix the valve, we haven't necessarily fixed their problems. There are certain factors that increase the risk of developing AS, and that includes advancing age, cardiovascular risk factors including high blood pressure, diabetes and smoking, as well as other comorbidities including chronic kidney disease and coronary artery disease. You can see by the busyness of this slide, really, this just describes how calcification occurs from inflammation, fibrosis. But the honest answer is we really don't know the exact cause of aortic stenosis and why it happens in some people and why it doesn't happen in others. We certainly know there are genetic factors as well as anatomical factors, including having a bicuspid valve, which makes it more likely to occur. This slide is very important. Aortic stenosis symptoms are not always easy to determine. The common ones that we would know about would be shortness of breath or chest pain or chest tightness, as well as feeling faint or feeling dizzy on exertion. But often we actually see patients with fatigue, reduced physical activity, or simply they've noticed that they just aren't as energetic as they were before, and occasionally patients can complain of palpitations. The onset of symptoms is very important because once patients have severe aortic stenosis and they develop symptoms, their mortality is actually quite significant. In fact, once patients do develop symptoms, if their aortic valve is not treated, 50% of these patients will actually be dead at 2 years. Severe aortic stenosis has a worse prognosis than many metastatic cancers, and the 5-year survival of aortic stenosis, if not treated, is about 3%, which is dismal. It's underdiagnosed and undertreated. It's underdiagnosed often because the patients are not necessarily being put in a position where they're having their heart auscultated, or if it is diagnosed, patients aren't necessarily having treatment for a variety of reasons, including comorbidities or perceived frailty. There are many ways that we can diagnose aortic stenosis, but we might start with auscultation. And auscultation is very important. I think it's probably underdone across all fields of medicine, certainly in surgery, certainly in orthopedic surgery, but I think in primary practice as well, it's not done for every patient, and there are certain patients who it probably should be done more often. One important thing to remember is that a faint murmur doesn't necessarily mean that it's a mild condition. If a patient has a poor left ventricle, the murmur can often be faint and in conjunction with a severe valvular problem. And an aortic stenosis murmur is normally, of course, a harsh ejection systolic murmur that's heard best over the aortic area, which may or may not radiate to the carotids. So if you turn up your sound for a moment, we've got some examples of what aortic stenosis should sound like. This is a normal heart sound. We all know that, of course. And this is aortic stenosis. And you can hear the typical crescendo, decrescendo murmur with a paradoxical splitting of the second heart sound that is pathognomonic of aortic stenosis. And that murmur can be heard up into the carotids, and sometimes actually if you put your stethoscope over the clavicle, it radiates the sound very well and makes it very obvious that it's an aortic valve problem. The main differential for aortic stenosis, if you hear a systolic murmur, is of course mitral regurgitation. And that should be heard best at the apex of the heart and radiating round to the axilla, and of course is a pansystolic murmur. So to really get a definitive diagnosis for aortic stenosis, we like to get an echo, and that's really the gold standard. It's used to assess the left ventricular function, the degree of wall thickening that may ensue from the narrowed aortic valve, as well as the presence of other valvular diseases, and of course the actual state of the valve itself, whether it's heavily calcified or bicuspid, or there's any other pathology going on there. You can see on the left-hand side the moving images, and on the right-hand side, the Doppler echo is actually how we determine severity, and we determine it by the following measures. severe aortic stenosis is defined with a mean gradient of greater than 40 millimeters of mercury, or a peak gradient of greater than 70 millimeters of mercury, or a valve area of less than 1 centimeter squared, or a peak velocity of more than 4 meters per second with Doppler echo. Remember that if the patient's left ventricular function is poor, the gradients might be lower, and actually the patient might still have severe aortic stenosis, and that's why it's very important to document their left ventricular function. With patients who are in an at-risk category above 65, where they are complaining of symptoms which might be attributable to a valvular disease, it is very important, obviously, to auscultate the heart. And if there's a suspicion of aortic stenosis, to actually send the patient for an echocardiogram, or both send them to a cardiologist for an echocardiogram to get the diagnosis. In the modern world, referring them to a hospital or referring them to a specialist usually means they're actually going to be exposed to a heart team. And the modern heart team includes a cardiologist, a cardiac surgeon, imaging specialists, a vascular surgeon, possibly an anaesthetist, really to try and decide what the best treatment options are for these patients, depending on their age and relative risk. The heart team tries to follow guideline recommendations according to what is the correct treatment for the correct patient, and these guidelines are based on evidence. What we do when we meet these patients and define or determine whether they have a severe valvular problem, we'll of course do a physical examination, an ECG where we might be looking for rhythm problems or left ventricular hypertrophy, an echo, which is really the gold standard. And then depending on which methodology we're planning on treating their valve with, if it looks like they are going to need some definitive therapy, then a CT angiogram to assess their ascending aorta and peripheral vessels, a coronary angiogram to determine whether they might need some coronary revascularization at the same time, some carotid Dopplers, and a frailty assessment where indicated. These are some sort of short examples. The TAVI, I think, in its infancy was really for very elderly, frail patients, and here's an example: an 88-year-old woman who's had bypass surgery previously. She's now oxygen dependent, has hypertension, a previous pacemaker, and NYHA class 3 dyspnea. She's got a poor left ventricular function with an ejection fraction of 35, and is considered to be extremely frail, with an STS risk score. The STS is the surgical risk score of greater than 8, which is very high. So if you look on the right-hand side of the screen here, you can see these are the things that we use to determine someone's risk. We use a surgical risk score like the STS score, with or without some measures of frailty, and there are a number of frailty indexes that we use, or more than 2 major organ systems compromised. And some of those patients, really, you do have to consider whether treatment of the aortic valve might be a futile exercise. But another example here is a 79-year-old female with no previous cardiac surgery, only comorbidities being diabetes and hypertension, as well as paroxysmal atrial fibrillation. And that patient has no indicators of frailty, is still working and has her own business. And if we put her into a risk score calculator, she, because of a number of her comorbidities, really would come up at intermediate risk, and therefore we really should be considering doing something about her valvular disease. Again, a third case, an 80-year-old male. He's never had previous surgery. He's got hypertension and non-obstructive coronary disease. His left ventricular function is mildly reduced, and again, he would be determined by a risk score to be intermediate risk, and therefore he could be offered either surgery or TAVI. So I've mentioned TAVI a few times, and this is really what we're talking about. It's a procedure where we put a tube up from the femoral artery. The patient can either be under general anaesthetic or under local anaesthetic. A wire is placed across the aortic valve, and then we put a sheath up through the groin, and then a device a TAVI device, there are either balloon expandable or self-expanding TAVI devices that can be inserted via the groin, and the device really is positioned using X-ray. In certain circumstances, we'd also use transesophageal echo guidance, and I'll just sort of move that forward. And then once the device is in position, and we're happy that it's in the correct position, we can deploy the device. In this animation, we're using a balloon expandable valve, and then remove everything and get the patient up for recovery. So the reason that we are sort of leaning towards TAVI where it's appropriate is because it does improve patient short and long-term outcomes in terms of or symptoms, as well as improves their long-term quality of life and life expectancy. The benefit of TAVI over something more invasive, of course, is that it's a shorter procedure. It's more comfortable for the patient. They've got a shorter stay in hospital and a shortened recovery time compared with surgical AVR. And I think, regardless of evidence in the past, patients have always been coming to us and voting with their feet and sort of asking why can't they have TAVI, even if they're low risk patients, and in some ways you can understand why. We, for a long time, have really been treating only the very highest risk patients because we didn't have data to support treating either intermediate or low risk patients, and those patients have traditionally still been sent for surgery. Over the last few years, however, there's been some very big randomized studies, and without going through all of those in great detail, this is an example from the Partner 2 intermediate risk study, where at 1 year, the composite endpoint of all-cause mortality and disabling stroke was actually 75% lower than surgery, with both of those indices independently also being better with TAVI than with surgery at 12 months. So I'm going to come back to our first case that I showed you. This is this patient, John Smith. He's 80 years old, number of comorbidities, as I mentioned, and this is sort of the patient journey. He would come in for a heart team decision and discussion, and in this case, because of his age and comorbidities, that decision was that he should have a TAVI. When he comes into hospital or prior to his hospital admission, he would have a dedicated TAVI CT scan that you can see here. And the idea of those really is that it gives us all the anatomical information that we need to safely perform the procedure. That includes his peripheral access as well as actually the aortic valve itself to determine the correct size of valve, and the ascending aorta and other anatomy to make sure that we have all the information we need to safely perform a procedure. The CT imaging is actually now gold standard in planning our TAVI procedures, and we really wouldn't be putting patients on the table without having some sort of dedicated CT imaging. This patient's procedure was done with one of these balloon expandable Edwards devices. You can see the procedure here. This is actually what we see rather than the animation. It's done under X-ray guidance. On the right-hand side, you can see the transesophageal echo images, which were taken as we were implanting the valve. And you can see that the actual implantation of the valve happens over a matter of seconds. There's a nice echo result on the left there with excellent hemodynamics, and on the right you can see with an aortogram there's no leaking of the aortic valve afterwards. And the patient was discharged on day 2 home. This is a little animation or a video just showing the difference between TAVI, where a patient's 8 hours post-TAVI and walking down the hospital ward, versus a younger patient in ICU at age 55 after having an AVR and stenotomy. So I'm going to give you another case example. Again, this one is a real case example. Mr. KR, with permission, he's a 53-year-old politician. He has an ejection systolic murmur with an early diastolic murmur. No symptoms. He has mild hypertension, drinks too much alcohol, 30 units a week, and no significant background medical history. A murmur was heard by his GP, and he was sent for assessment, and his echo on the left showed normal left ventricular function with very severe aortic stenosis, a peak jet velocity of 5 meters per second, which is actually classified as critical aortic stenosis, and a valve area of 0.59, which is very severe. You'll also notice on the echo where the arrow is pointing that instead of 3 leaflets, he's got 2 leaflets. So he's got a bicuspid aortic valve with critical aortic stenosis. And on the right-hand side, you can see he's got normal coronary arteries. And we obviously have to make a decision on what to do. He had a CT which confirmed his bicuspid aortic anatomy. His ascending aorta wasn't dilated, which it can often be with bicuspid aortic valves. And so the decision to do anything really rested just on his aortic stenosis. So we've got some treatment options. There's medical treatment. We generally follow a lot of patients with no symptoms with medical treatment, i.e., and as you know, medical treatment for aortic stenosis, there's not really any effective tablets. Occasionally we would use diuretics, but really if we're at the point where we're using diuretics, the patients are symptomatic, so we should be thinking of alternatives to replace the valve. In this situation, where a patient's actually got critical aortic stenosis, it would be one of the few indications where we might consider definitive treatment even without symptoms. And so for this man, he's in his 50s. We've got a choice between TAVI or surgical AVR, and if surgical AVR, what type of valve would we use? And so in this patient, we actually felt that given his young age, that surgery would be the most appropriate treatment. And mechanical versus bioprosthetic surgical valves is always a difficult decision. Of course, if you have a mechanical valve, you are committed to warfarin lifelong. And if you stop the warfarin, it can be very dangerous. So if you need any surgical procedures in the future, that does put you at increased risk. And of course, being on warfarin has its own risks in terms of bleeding. A bioprosthetic valve is in some ways a more appealing option to many, but it does mean that on average, a bioprosthetic valve will fail after 10 or 15 years. And therefore, for a young man in his 50s, he may need a second procedure. I think in the older days, the second procedure automatically meant an open surgical procedure. And so with the advent of valve-in-valve procedures, a man like this could consider having a aortic valve replacement with a bioprosthetic valve. These are just, sorry, I'll go back. Some pictures from surgery. You can see, you know, the bicuspid valves are often heavily calcified. And you can see the slit-like orifice, which is typical for a bicuspid valve. And sometimes with all that calcium there, it might actually be preference long-term to get some of the calcium out and actually excise the valve and replace it. I'm going to give you another case example. This is a 75-year-old woman with exertional chest pain. She's got type 2 diabetes. She's got severe aortic stenosis on echo. She's got a little bit of kidney impairment and found to have diffuse 3-vessel coronary artery disease on her angiogram. So on the left-hand side is a picture of her right coronary artery with 2 or 3 severe stenoses. On the right-hand side, you can see she's got a severely diseased LAD and distal circumflex. So this is a lady with severe AS and 3-vessel coronary artery disease. She's intermediate risk, meaning she could have either TAVI or surgery. And because of the coronary artery disease, actually, at the heart team meeting, we elected that she should have an aortic valve replacement and coronary artery bypass grafting at the same time. So case 4, an 82-year-old woman with exertional breathlessness. She had recurrent pulmonary edema, moderate coronary artery disease, severe aortic stenosis, and significant peripheral vascular disease, and was deemed by the heart team meeting or the MDT to be inoperable by the surgical team. Her CT really did show severe lower limb peripheral vascular disease with no good access options to try and get our TAVI device in through the typical transfemoral approach. Now, there are other ways. If the patient really doesn't have a surgical alternative, there are some non-femoral vascular options we can use, including from the direct aortic approach by making a sort of small incision on the right-hand side of the chest. We can go transapical under the rib or between the ribs at the apex of the heart, and more recently, subclavian approach, carotid approach, and actually we were the first centre in Australia to do a successful transcatheter procedure. This lady had very poor femoral access on CT, but with some careful CT planning, we were able to find a point where we were actually able to cross over from the inferior vena cava into the aorta and place a tube from the IVC punctured across into the aorta. And then on the right-hand side, you can see afterwards, we actually put a plug in the aorta to close that and successfully treated her valve. A fourth case example is of a 61-year-old medical negligence lawyer. He's got mild hypertension, no symptoms at all, exaggerated blood pressure response on his executive health screening, drinks far too much alcohol and has no significant medical history otherwise. He had an echocardiogram and was found to have a very dilated ascending aorta with a trileaflet aortic valve, but his ascending aorta measured 49 to 50 millimeters, so by definition he's got an ascending aortic aneurysm, and had a CT scan, which really is the gold standard for looking at ascending aortic dimensions in 3 dimensions, and he actually had a 52 millimeter ascending aorta on CT. He's got a trileaflet aortic valve, so there's no reason to operate just because of the valve, and the question really is, what do we do with him? These are always difficult decisions because anybody with significant ascending aortic dilatation is at risk of aortic dissection. And there are some guidelines, but the guidelines are obviously only guidelines and do depend on the individual. Certain people are more at risk of aortic dissection at lower diameters or lesser amounts of ascending aortic dilatation, and they include patients with bicuspid aortic valves, patients with connective tissue diseases, or people in pregnancy, or if they have a family history of aortic dissection. Our cutoff normally would be 55 millimeters to insist on surgery in somebody with none of these factors. If you have any of these factors, that cutoff would be either 50, or sometimes even in someone with Marfan's disease, we'd think of replacing the ascending aorta at 45 millimeters. The other factors, of course, are if the dimensions of the ascending aorta have changed quickly over a short period of time. So if they've gone up by more than 5 millimeters in the last 12 months or so, then you might reconsider an earlier surgical option. So I'm going to sort of summarize because we've got Professor Muller next to me who's going to go through some more case studies of aortic and valvular disease. 1 in 8 people over 75 years is affected by aortic stenosis. Timely intervention is key. Without treatment, up to half of symptomatic patients will die with an average of 2 years if they're not treated. So whenever you have somebody who has any symptoms, and even somebody who is elderly who may not have had their cardiovascular system assessed for a while, please listen for a murmur. If you hear any systolic murmur, even if it's soft, send the patient for an echo and or a cardiology consultation, and we can rule out this very important and dangerous disease. This is just a little video of Mick Jagger, who did have a TAVI, and this is him 2 weeks after his TAVI procedure, doing his dance rehearsals for getting back on tour. So I'm going to stop there, and if anyone has any questions or discussion points, there were some questions sent in, and we would probably leave those till a little later on. I think what we might do is let Professor Muller give his presentation, and then if there are questions not relating to valvular disease, we could cover those then.
Great, yes, we have a few questions that have come through, and if anyone else has a question, just use that question bar on your screen to submit them. So the first one is the patient exposed to above average radiation during the TAVI procedure?
Excellent question. So is a patient exposed to more radiation during a TAVI procedure? Yes, in terms of more radiation than sitting at home in bed, but a TAVI procedure really is what used to be 10 years ago a 2-hour procedure with a lot of careful considerations about groin access. Now, really skin to skin, the procedure is about 30 minutes. Most of that is actually not screening time, so there'd be about 4 minutes of screening time, which is very similar to a percutaneous coronary intervention procedure. So there's actually not a lot of extra radiation as compared to a coronary procedure. There is some radiation associated with the CT scan, of course, and the patient, if, you know, when we think about their whole treatment journey, they would need a CT scan and the definitive procedure. But of course, even if they're having surgery, we would, you know, these days insist on a CT scan so that we can document the calcification of the ascending aorta and the dimensions of the ascending aorta to determine whether that needed to be replaced as well. So, you know, I think the radiation dose is not so much. It would be sort of somewhere in the region of 4 or 5 millisieverts in total, which is not a lot.
Great. So the next question is, would you echo everyone with an SEM if they were over a certain age?
I think I would echo everybody with a systolic ejection murmur or a systolic murmur at any age. I mean, I think, you know, the cutoff might be if you had somebody who was in a nursing home who no action would be taken no matter what you found. But I think, you know, I'll give you an example of a young man I met yesterday who was told he had a congenital aortic stenosis, and actually it turned out that he had a bicuspid valve, and at age 35 he actually had severe aortic stenosis, and he's going to need to think about having something done. So at any age, if you hear a murmur and that hasn't previously been documented as to what that murmur is, then I'd send them for an echo.
The next question is, are there risks long-term if the patient has already undergone a CT angiogram or coronary angiogram prior to TAVI?
Are there risks long-term? I'm not sure I understand the question exactly. Does this relate to radiation? I mean, most of the patients would actually have had those things before their TAVI, because when we are having our heart team meetings or MDT discussions, we want all of the information. If somebody's got terrible coronary disease, then actually they might be better off having open surgery where they could get a bypass and the valve dealt with at the same time. So we're not really, at the moment, we don't do a TAVI and a coronary angiogram in the same sitting. They're actually done beforehand.
Right, and the next question is there a risk of CVA with the TAVI procedure?
Yeah, good question, and that was actually dealt with in the presentation slides. But you know, the original TAVI trials, remember, were of patients who were, strictly speaking, inoperable. So these patients were in their late 80s. They were deemed inoperable by the surgeons, and they were the worst of the worst vasculopaths. And you know, some of the original trials had stroke rates in between 4.5 and 5%. The intermediate and the low risk trials now, the stroke rate's approximately 1%. In the low risk trial, it's actually less than 1% and actually less than aortic valve surgery. Further to that, we've got embolic protection devices that we can use in selected patients. So we've got a little device that we can put up from the radial artery that can actually cover the head and neck vessels and prevent any embolic debris from causing stroke. At this point, we're not using them for every single patient, but if patients have certain risk factors, either they've got atheroma in their aortic arch or they've had a previous stroke, then we'd certainly be considering using it.
Great, and the last question is, does the patient have to be on anticoagulants post-procedure?
Excellent question. You know, as you know from, or as we know from bioprosthetic surgical valves, so if someone's got a pig or a cow valve and they've had an aortic valve replacement, we would generally just give the patients aspirin. If they've had a valve put in the mitral position, then we tend to lean towards anticoagulation with warfarin because it's a lower flow state, and often you are more at risk of clot forming, although it's not absolutely necessary if it's a bioprosthetic valve. If it's a metallic valve, obviously everybody needs warfarin. For TAVI devices, we use antiplatelet therapy. The commonest regime would be to give 3 months of aspirin and clopidogrel and then follow with a single antiplatelet agent afterwards. But we do this on a case-by-case basis, meaning if somebody has an increased bleeding risk, we would use single antiplatelet therapy, but certainly for standard TAVI procedures, anticoagulation with warfarin or a NOAC is not required.
Great, well, that's all the questions, David. Like you said, we had some pre-submitted questions that we can go over at the end of the webinar, but thanks for your time. We might move on to Associate Professor Muller.
Thank you very much, thank you.
Okay. So David Muller will be speaking on the examination of the cardiac patient.
Good evening, everyone, and thank you for having me, and welcome to the second part of this webinar. It's getting late into the evening. I hope you've managed to get something to eat and hopefully a glass of wine while you're doing this. My presentation will be quite a bit shorter than David's. David has been very thorough in covering all of the basics of aortic valve disease, and I hope giving you a reasonable indication of what options we have now for treating patients with aortic valve disease. I'm going to use just a couple of cases to amplify some of the things that David has already alluded to, and then leave plenty of time for questions, because there were quite a few that came in before the session, and I hope there'll be a few more relating specifically to this presentation or to David's that we can address. So I'm going to just start with this gentleman, who is a fellow I've known for a while. He's 89 years old. He has a few risk factors for coronary disease. He has some coronary disease. He had a stent in his diagonal branch about 5 years ago. He's had a permanent pacemaker for some conduction delay. He's been known to have aortic and mitral valve disease for some years, but has been doing well until the last 12 months or so, when he became increasingly breathless. He's had no chest pain to suggest a problem with his coronary arteries. He's generally in pretty good condition for 89. He's cognitively in good shape. He lives fairly independently with his wife and can deal with most normal activities, but increasingly he's complaining of breathlessness. His echo, which I will show you, now shows severe aortic valve stenosis. He's got, in addition to that, severe eccentric mitral regurgitation, some left ventricular hypertrophy, but pretty well preserved left ventricular function. His pulmonary pressures are starting to sneak up a little bit. He's got a pulmonary artery systolic pressure of about 60, and he has had a follow-up angiogram that shows diffuse coronary disease. So this is a man that we're going to almost certainly think, if we're going to add anything to this, if we're going to treat this gentleman at all other than medical therapy, then we will be looking to probably treat this gentleman with TAVI. I'm just going to clear that. So the question then is, how do we evaluate this man as a TAVI candidate? The first thing to say is that at 89 years of age, our surgeons don't really have a great deal of interest in operating on someone that age. And by and large, we have a reasonably good understanding with our heart team, our surgeons, our general cardiologists, that anyone over the age of 80, even if they're considered relatively low risk for surgery, would be worked up towards a TAVI procedure. And as long as there's no contraindication to TAVI, then the heart team is likely to recommend that he has a TAVI procedure. Now, there are a few exceptions to that, obviously. It depends a lot on other comorbidities. And in this case, we have someone who's got multi-valve disease. So there may be other considerations here. David, I think, alluded to some of the other things that we need to know about this gentleman. One of the good things about this fellow from a TAVI point of view is that he has a pacemaker already. One of the complications of TAVI is that, particularly with the self-expanding valves, there is a risk of interfering with the conduction. The conduction pathways run very close to the aortic valve, and the perivalvular fibrosis and calcification that happens in aortic stenosis can mean that many of these people have already got compromised conduction. And by leaning on the conduction system with a balloon expandable or a self-expanding valve, there is a risk of needing to treat them by pacing after the valve has gone in. So this is a big plus from a TAVI point of view, that this is a man who's already got a pacemaker. That's one less thing to have to worry about. David's already talked about evaluating from a point of view of access, peripheral access. We need to know whether we can get through the aortic valve. We need to know a little bit about the coronary heights. These are all things that we get from the CT angiogram. One of the other risk factors for TAVI procedure is that the TAVI can cause the old leaflets to obstruct the coronary artery. So we're very careful in measuring the height of the coronary arteries above the annular plane. So all of these things are evaluated on the CT angiogram. We can make some very careful calculations and estimation of risk. And if we do our sums carefully, most things are manageable and avoidable. The one thing, unfortunately, there's a little bit less clear is the risk of stroke and how do we predict that. At the moment, we are not very good at predicting stroke. Fortunately, the stroke risk is now of the order of 1 or 2% at most. So what did we find out with this gentleman? Well, I'm just going to show you a couple of things related to him that made his made decision-making a little more challenging. So on the left, you can see this is a 2D echo of his left ventricle. This is the left LV here. This is the aorta, and this is the left atrium. So this is the mitral valve between the left atrium and the LV, and the aortic valve between the LV and the aorta. If we look first of all at his aortic valve, you can see this is quite bright and thickened looking. There's very little movement of the leaflets here. This is a calcified, obstructed aortic valve. So he has aortic valve stenosis just looking at this. If we come back to the LV, you can see the LV is working well, but the LV is quite thick. So it's actually got significant left ventricular hypertrophy. Sometimes this hypertrophy actually starts to impact on the LV outflow tract here. So even if you fix the valve, the knuckle of left ventricular hypertrophy can still leave a gradient across the outflow. But this LV hypertrophy is important because it makes the heart stiff. You can fix the valve then, and you're left still with a stiff, non-compliant, poorly relaxing left ventricle that still can leave the patient breathless with exertion. So it's important to note that it doesn't really make much difference to the procedure, but it does make some difference to the likelihood of getting a really good clinical result, or whether you've got somebody who has had a successful procedure but remains breathless because of their diastolic dysfunction. The other thing to note is this is the mitral valve at least. So the mitral valve has two leaflets. One is the anterior leaflet, the other is the smaller posterior leaflet. And you can see that this valve opens well. There's no restriction to opening, but when it closes, the anterior leaflet overrides the posterior leaflet. So this is anterior leaflet prolapse. And the reason that's occurring is because of another degenerative condition, and that is caudal rupture. So the leaflets are held down in the ventricle by the papillary muscles, which are attached to the leaflets by chordae. Now, if those chordae break or stretch, then the leaflet will prolapse, and then we get failure of coaptation here and mitral regurgitation. So this is an elderly man who has not only aortic valve stenosis, but he's also got left ventricular hypertrophy, which is important, and he's also got an abnormal mitral valve. This is his aortogram. You can see there is calcification in the aortic leaflets here. There's no dilatation in the ascending aorta. It's important for all the reasons David alluded to, that if the aorta itself is markedly dilated, then we really start thinking surgery rather than TAVI. There's no aortic regurgitation, so there's no dye coming back through the valve into the left ventricle. And these, of course, are his pacing leads, which we're always pleased to see in planning a TAVI. So this gentleman is 89 years old. He's not really frail, but he's not robust. He's certainly an 89-year-old, 89. He's going to need 2 valves dealt with. And double valve surgery in an 89-year-old is a challenge. It's got a very high surgical risk. From a point of view of medical therapy, we know that there really isn't any medical therapy that will fix the aortic valve stenosis. And the combination of AS and mitral regurgitation is bad physiologically, because all of that pressure generated by the LV trying to push blood out through the obstructed aortic valve results in an increase in the severity of mitral regurgitation. So the combination of those two together is not good. Clinically, it can be really quite a challenge to decide which is the dominant lesion. Is it the aortic valve disease? Is it the mitral regurgitation? How do you distinguish that clinically and by echocardiography? Could we get away with just fixing one? What, say we just fix the aortic valve, would that be sufficient? He is, after all, not planning to leap tall buildings. He wants to be able to walk to the bathroom and back without getting breathless and go on the occasional Sunday outing. He doesn't need to have a perfectly good heart. Do we need to fix both, or is he still going to be symptomatic? If we do fix both, can we expect him to be very good, able to do everything he wants, or is he still going to be limited by something? And that something in this case would be his left ventricular thickness and stiffness and the failure to relaxation, which is called diastolic dysfunction. So we can fix all these valve problems, but not fix him if he has a severe degree of left ventricular hypertrophy and diastolic dysfunction. Now, in terms of clinical evaluation, David's already taken you back to medical school to give you some idea of the heart sounds you expect to hear. And I just really wanted to touch on a couple of things that can be confusing and can help it make it difficult to understand the difference between aortic stenosis and mitral regurgitation. They are, after all, both systolic murmurs, and I'm not sure whether everyone in the audience was able to hear the difference between the aortic stenosis that David played and the mitral regurgitation, which can sound very similar. If you've got aortic stenosis, the important things that you might recognize are that the pulse tends to be a slow rising pulse. You can typically feel a thrill at the base, so that's up in the second right intercostal space. You can feel a thrill if you put your hand on the chest wall, and that's a systolic thrill. That's a pretty reliable sign. You can have a very loud murmur that might actually be only mild aortic stenosis, but once they've got a thrill that you can feel, then that typically denotes a very stenotic valve. The second heart sound is typically soft because the valve is not moving much. The murmur is typically a harsh ejection systolic murmur up on the right, second right-hand intercostal space, which radiates into the carotid. So that's the typical appearance. But importantly, you should know that the degree of the loudness of the valve does not correlate well with the severity of the murmur. You can have a very harsh murmur with a very mildly stenotic valve, and equally you can have a soft murmur for someone who's got a poor LV and very severe aortic valve stenosis. Now, what about mitral regurgitation? Well, the first thing is the pulse character is typically normal, but often they will be in atrial fibrillation because the MR causes quite significant left atrial dilatation, and that left atrial dilatation triggers atrial fibrillation. You won't find a thrill anywhere at the apex or up in the aortic area. The heart sounds can be difficult to hear, particularly if you have a pansystolic murmur. And then the tricky bit becomes if you have someone with prolapsing mitral valve and mitral regurgitation, because that is not the classic pansystolic murmur. It's typically described as a mid-systolic murmur, so it's the first part of the diastole of systole is actually fairly quiet, and then you hear it start to amplify in the middle part of systole. So that can sound very much like an aortic systolic murmur if you have a mitral murmur that is not a pansystolic murmur. And typically, yes, it is true that most mitral murmurs radiate from the apex into the axilla, but that's not true of all mitral regurgitation. Some of the mitral regurgitant jets, if you look up at this little schematic here, you can see that this is a prolapsing mitral valve, and it depends on which leaflet is prolapsing. If it's the anterior leaflet, the jet will go backwards towards the posterior wall, and that will sound like a typical mitral murmur. But if the posterior leaflet is prolapsing, the jet will typically run up along this anterior wall in the same direction as the aortic itself. So any murmur that's generated by a posterior prolapse will often sound like something that's going up to the aortic area. It's not usually heard in the carotids, but it can sound very much like aortic valve stenosis. So you can be forgiven for not being confident with some of these. They can be very hard for all of us to know whether this is truly aortic stenosis and or mitral regurgitation. And someone who's got both can be very difficult. Of course, if you've got aortic valve stenosis, one of the important things to look for is left ventricular hypertrophy on their ECG. The ECG on the top left has high voltages, particularly in the limb leads. It's important whenever you see an ECG that shows big voltages to look at the voltage measure here, because every now and then the echo tech will amplify this, and then that can erroneously make these look tall when they're not really supposed to be. This patient also has some ST segment changes laterally, which are also consistent with left ventricular hypertrophy. But this is not much going on here. It's mostly confined to the limb leads. In contrast, this one shows very much more severe left ventricular hypertrophy. You'll see that there are very tall voltages here. This goes down below the cutoff of the page here. This one goes up, well up to here. So these are very tall voltages across the chest leads. And you have, again, some ST segment depression, a typical reverse backwards tick, if you like, which is typical of left ventricular hypertrophy. Of note here, of course, there's some ST segment elevation you'll have noticed. This is not an anterior infarct. This is ST elevation relating to the presence of left ventricular hypertrophy on this quite severe example. Now, when we're looking at these ECGs for someone who might be considered a TAVI candidate, we're also interested in what's the likelihood of causing this patient to need a pacemaker after the fact. And the things that we know that predict that are evidence of conduction delay on the ECG, in particular a right bundle branch block. So someone who's already got a right bundle and we lean on the left bundle with the new device, that can be enough to tip them into complete heart block and the need for a permanent pacemaker. So very occasionally you might hear of us pacing someone ahead of time, and that's because they've got, for example, a first degree heart block with a right bundle branch block. That patient will almost certainly need a pacemaker afterwards, and it's just a lot cleaner and easier to get the pacemaker done before the TAVI procedure. So, as I said earlier, if someone's already got a pacemaker, that just makes our life so much easier. In terms of echoes, you will know that there's a couple of ways of measuring that. David's alluded to some of them. This is the aortic valve here. You can measure the gradient across that valve. You can look at the motion of the aortic valve in cross-section. And then in actual cross-section of the valve itself, you don't always get pictures as nice as this, but you can actually planimeter the area of the valve when it's fully open. And it should be very much bigger than that. It should be, close to 2 square centimeters. Anything less than 1 square centimeter is considered severe. And we commonly see patients who have a valve area of 0.5, 0.6, 0.7 in the very severe or the critically severe aortic valve stenosis. So this is aortic stenosis with left ventricular hypertrophy. What about mitral regurgitation? We should talk a little bit about the pathology just so we understand exactly what this patient had. The important things to know about the mitral valve is it's a very different animal from the aortic valve. It's a much more complicated structure. Instead of just having leaflets that open and close, the mitral valve has two leaflets that are held in position by chordae. These are the caudal structures that attach to papillary muscles, which in turn are part of the ventricular wall. So we talk about the leaflets, the chordae, the papillary muscles, and the ventricle in terms of the apparatus, the mitral valve apparatus. And there are two types of mitral valve regurgitation, if you like, that can be broadly grouped into what's called degenerative mitral regurgitation, or now called primary MR. And that relates to any of the leaflets becoming abnormal or the caudal structures becoming abnormal. And this is a condition that is typically seen in the elderly, like our man, the first case we mentioned, who's just got degeneration, eventually stretching and fraying of those caudal structures to the point that one of the leaflets, or perhaps both of the leaflets, then prolapse into the atrium and allow a jet of mitral regurgitation to go backwards into the left atrium. Mitral regurgitation due to primary MR is also probably an inherited condition. So the other group that we typically see are the 40, 50-year-olds who might have a family history of mitral prolapse, mitral regurgitation, and they can present early. They can present pretty suddenly sometimes with a complete rupture of that caudal apparatus, and very severe mitral regurgitation can be life-threatening presentation. So that's degenerative MR. It is a pathology of the leaflets or of the caudal support structures. Functional MR is a common problem as well, and that's not anything to do with the leaflets or the caudal structures. It relates to the size of the annulus, so anything that causes the annulus to enlarge and pull the leaflets apart will cause mitral regurgitation, as will anything that causes the left ventricle to enlarge, which then pulls on the papillary muscles and the chordae and brings the leaflets into the ventricle so that they can't coapt again. So this is functional or secondary MR. It's MR that is secondary to an abnormality, typically of the left ventricle, perhaps sometimes of the left atrium itself. So this is mitral regurgitation. Our gentleman had a primary or degenerative mitral regurgitation, as is commonly seen in the elderly. So this is what his procedure was. We elected to treat his aortic valve first. One of the hopes is that if you treat the aortic valve, perhaps the mitral will get better. That's certainly true for functional MR, but probably not really true for primary MR, because it's a mechanical problem. The support structures are not going to really change if you fix the aortic valve. But this is our valve. I think David showed you one of the balloon expandable ones. This is a self-expanding valve. There's no leak there at all. It's sitting in a good position. There's good flow into the coronaries. He's already got a pacemaker, so this patient should do very well, except for two problems, I guess. One is he's still got mitral regurgitation. So what are we going to do about that? And the second thing, I guess, is that even if we fix that as well, are we going to fix the patient if he's still got significant diastolic dysfunction? So in fact, we sent this fellow off hoping that he would be very much better just having his aortic valve treated, but he really hasn't improved. He's very breathless still. He's not happy with his ability to get around the house. And the reason is because of this severe eccentric jet of mitral regurgitation. Now this is, I mentioned, an anterior leaflet, so it's going posteriorly. So this would sound like a typical mitral regurgitant murmur. This is a transesophageal echo. Often you need to do a toe to be able to characterize the severity, because these eccentric jets can be hard to find on a transthoracic echo. So if it doesn't make sense, if someone's very symptomatic and the transthoracic echo says that they've only got moderate or mild to moderate MR, it may be they just haven't been able to see the severe eccentric jet that would be much more readily seen on a transesophageal echo. So don't forget that the toe is a good way of finding these eccentric jets and recognizing patients with severe MR. So what can we do for him? Well, there's a couple of options, but one of the things that's been done for a very long time is Mitraclip. It's not been done in this country for quite as long as TAVI. We were involved with the first TAVI procedure in 2008 and the first Mitraclip procedures done in 2011. So these have been around for a while, and he would be a very good case, very good and anatomically for a Mitraclip. What you'll see in the top left-hand panel is the clip. This is done from the femoral vein, so it's a fairly low-risk procedure in terms of bleeding. We cross through the septum and come down into the left ventricle from the left atrium. Sorry, let me go back. And this you can see is the clip when the clips are open completely. You pull it back into the valve so that the two leaflets, what we'd like to talk about, dancing on the platform of the Mitraclip. Once it's sitting in the right place, then we can just close the clip, and you end up then hopefully having something that looks a bit like this, holding the leaflets together in the middle. So if you were to look down on the mitral valve from the left atrial side, this is now, you can see a mitral valve that is double barreled. So we've got a clip here in the middle, and instead of a single barrel orifice, we have a double barrel orifice, and that in a normal mitral valve is sufficient to allow blood flow in without creating a gradient and stop it from coming back because you've controlled that flail segment that was in the middle of the mitral valve. And this is just a pretty picture of it in 3 dimensions. So this is what we hope we can see in a patient who's had a clip. The clip controls the mitral regurgitation. It's probably not, well, it isn't as good as a surgical operation because we quite often still have mild or moderate mitral leak, depending on the complexity of the pathology. We often still have some residual MR, but it's enough to make a very big difference and keep people out of hospitals. So our gentleman, the first case has not got as good a result as we had hoped from his aortic valve procedure. So he's been scheduled for a Mitraclip procedure. This is a pretty straightforward procedure. You can be very elderly and very frail and still get through a clip procedure without too much difficulty. It is done under general anesthetic, but it's a light GA. It's mostly guided by transesophageal echocardiography, and most patients are ready for home the next day or perhaps the day afterwards. So there are ways of doing combination treatments. Once upon a time, having multiple valves involved meant that we often balked at doing anything and just said, look, this is too complicated. We can't treat all of this. We'll treat others. We'll get a better result. But now we can treat aortic valve disease. We can treat mitral valve disease. We're also in a position now to start thinking about treating tricuspid valve disease in the hope that some of these with more complex valvular or structural heart disease can get a good clinical result. This man, of course, will still be left with diastolic dysfunction from his left ventricular hypertrophy, and every now and then those patients are still pretty miserable and still fairly breathless. So we have to warn the patients that that's possible. I might hold there just for a moment before going on to the next section, just to see, Roy, if you've had any questions come through, particularly related to TAVI procedures in this sort of situation, evaluating people ahead of time, or perhaps multi-valve disease and Mitraclips.
Yeah, a few have come through. So the first is, do the TAVI self-expandable valves come in different sizes?
Yes, they do. There are 4 different sizes. They range from a 23 millimeter valve, which is relatively small, up to a 34 millimeter valve, which is big. That's very big. There aren't many people who don't fit in those 2 sizes. We can almost always find a size. There'd be very few patients who we can't fit with one or other of those devices.
Great. The next question is, what percentage of patients need a pacemaker after TAVI?
So that depends a little bit on some of the things we talked about, what their conduction looks like. But you know, there are some patients who've got right bundle branch block, for example, who you can almost guarantee that they're going to get a pacemaker. On average, the literature would say that with the balloon expandable valves, it's about 8% or so, 6 to 8%. With the self-expanding valves, it's more like about 15%. In our own hands, we've been working fastidiously at putting these valves up high in the annulus, and if you do that, you can get a single-digit pacemaker rate. So our own pacemaker rate for the self-expanding valves is about 6 to 8. It's about the same as the balloon expandable valves.
And the last question so far, you might have answered already, but it's when is TOE, toe indicated for patients being assessed for TAVI?
For TAVI, it's probably not all that critical. There are certainly patients in whom we have very great symptoms. People are very symptomatic with breathlessness, for example, and the echo suggests that in fact the gradients are not all that high. They might have a bit of diastolic dysfunction. We're just not sure whether it's the valve is the problem or whether it's their stiff heart that's the problem, or whether they've got some other explanation for their breathlessness, their lung disease. The toe is a good way, a very good way of being able to see the valve in cross section and to be able to see the leaflets actually moving, to get a better, to actually planimeter the valve very accurately. And it's the best way, I think, of actually trying to distinguish in a low gradient situation whether it's the valve that's a problem or not. But no, it's not routine. We don't need it for routine workup for a TAVI patient.
Perfect. That's all the questions so far.
Very good. I'll move on to another section, which is really fairly quick, I think. Yeah, we've got time, I think. Hopefully people are still with us. So this is a second section. Again, just to highlight a couple of points. It's just to show you another consideration. This is a man who's 80 years old. And in contrast to the last fellow, he has had an aortic valve replacement. He had what's called a perimount valve, which is a bioprosthetic valve, and a single graft inserted in 2003. He's got some chronic renal impairment. Most importantly, he really did not like his last surgical procedure. He took a long time to recover. He had pain in his sternal wound for quite a long time. He did well for about 15 or 16 years, but is now starting to get the same sort of symptoms. He's breathless. He's not had chest pain. But on echo, he's now got a valve that is not working well. It's a very leaky valve. He's still got good LV function. He's got patent coronary arteries and a patent graft. And on the numbers, his STS score, which is a way we can estimate the risk of dying from valve replacement surgery, is 8%, which would be considered a high-risk surgical proposition. So the question is, what can we do for this gentleman? 80 years old, he's had one operation. Is there something we can do short of surgical valve re-replacement? And the answer is yes, we can. We now have quite an experience with what's called valve-in-valve TAVI. So this is what his valve looks like. This is a perimount valve. Now, this is the best valve for us because it's a valve you can see very easily. You can see where the annulus is, you can see where the crowns of the valve are, and it's relatively straightforward to place a valve into that. This is what it looks like on the table on the top left-hand side, and this is what it looks like radiologically. And this is our self-expanding valve, and we aim to put it very high in this annulus, the bioprosthesis at least. And the important thing to know about this is that one of the reasons we typically use the self-expanding valves for these valve-in-valve procedures is that the design of the valve is to optimize the effective area of the valve itself. So instead of the leaflets being down at this level in this prosthesis, they're actually up at this level. So they're well out of the original annulus, they're well above the surgical annulus, and that means it can expand here to something at least of the size of the original annulus. If you were to put in a valve that sits in here at this level, by definition, you could never have a new orifice that's as big as the surgical orifice and certainly not as big as the original native orifice. So this is a valve in valve. Typically, the self-expanding valves are used because of that supraannular position of the leaflets. And this is what it looked like. We put it very high, again, to avoid pacing. This is the valve sitting here. The plane of the new leaflets would be up here, not down here. And we've avoided leaving any metal in the left ventricular outflow tract, which is where we think the problem is with pacing, the need for pacing. No residual leak at all. So this is a good result. This patient did well and should expect another 10 or 15 years from that procedure. So these, just to show you, if you like, increasing degrees of difficulty. We seem to have had a run of these in the last couple of weeks. This is the perimount I mentioned. This is a mosaic valve, which doesn't give us quite as much information fluoroscopically. It has some little islets in the top of the peaks of the crowns here, but nothing down at the annular level. And the worst of all is the freestyle aortic root. This is a pig aortic root that's got a valve in it. It's got a cuff of aortic root, but there is no metal in it. There's no material in it that we can see fluoroscopically. So they can be a real challenge. This is the mosaic one we did yesterday. This is a valve. You can see the islets, which sit up fairly high. They're not at the annular level. And this is where we put the valve, and you can see it's just a little squirt of residual leak here, but a good result. No gradient across the valve there. So that was an Evolut R self-expanding valve in valve procedure. The more difficult one is the freestyle valve, because there's just nothing to see. You cannot really see where the valve is. You have to make your best guess and try to figure out where to put the new valve. And we, I think, got a reasonable results, perhaps a little bit lower, and maybe because of that, we've got a little bit of residual leak here, but no gradient, and this patient did well, and I'd expect that patient to continue to do well again for another 10 or 15 years. So finally, I want to finish with one other concept, and I'll use this patient to illustrate it. This is a 76-year-old lady who had a congenitally bicuspid aortic valve that was treated surgically 14 years ago with a perimount valve, and she presented with breathlessness again due to dysfunction, degeneration of that aortic bioprosthesis. She had no conduction disease on her ECG, she had eccentric AR, no coronary disease, and good access to her valve from the leg. So at 76, someone who's already had one operation, our heart team felt it reasonable to offer her a valve in valve TAVI, and that's not the point of this exercise. This is just to show you that we did the procedure. But we did this as part of a consideration of an early discharge program. Now, we've had over the years a gradual reduction in involvement of our anaesthetists. When we started these procedures 10 years ago or 12 years ago, the anaesthetists treated all our patients as if they were having their chest open. So they intubated them, they put transesophageal echo probes down, they had radial lines in, urinary catheters in, central lines in, and monitored everything. They put in inotropes just to make sure everything went well. And it's taken us some time to wean them from those, to the point that now this is very much a local anaesthetic procedure, often with a little bit of sedation, but we try to keep that to a minimum. We're now trying to keep all unnecessary lines away, no urinary catheters. We often do them in the healthier patients without central lines, without art lines, and patients go to this coronary care unit. They're not going to ICU. They are monitored for a day or two to look for evidence of increasing conduction disturbance, but we get them up quickly, either later in the same day or the next day. They have an echocardiogram the second day, or first post-operative day. Provided they have normal hemoglobins and creatinine, then we can start to think about getting them home either the first post-operative day or second post-operative day. This lady had a normal hemoglobin, she had normal renal function, she had no conduction change, she felt well, and we sent her home early on the morning of the second post-operative day. I don't think we've touched on, we should just touch briefly on creatinine and renal function. That's probably one of the limiting factors of TAVI procedures or surgery for that matter. But in someone who's got a creatinine of 200, 250, we have to use contrast for these procedures and certainly for the weight workup. So we haven't been able to convince our radiologists to give us a good quality image without using about 80 mils of contrast. So patients who have very poor renal function, we have to try to cope without CT angiography. We can do that. We have done that. We've got away without wrecking the kidneys, but there's always that risk that we will use too much contrast in patients who have very poor renal function. So that's an important part of the workup, understanding what the risk of renal failure might be. But it's certainly something we check afterwards. We check their hemoglobin to make sure they haven't bled too much, make sure their renal function's okay, make sure there's no conduction disturbance. And if possible, send patients home on the second post-operative day. We had a recent webinar with a team from Vancouver just to discuss this, particularly in the time of COVID, when we want to get people out of hospital. So the title of the webinar then was TAVI in the time of COVID. And they spent a lot of time talking about their program for early discharge. And this was one of their slides. These are two patients up and about on the same day of their procedure, watching TV, ready for discharge the following morning. They have actually discharged patients on the same day. So this is a very much less intense procedure than when we started this 12 years ago. The most important things in terms of early discharge is to start to manage very early in the workup of these patients the expectations that they will not be in hospital for a week. It's so remarkable how often the families expect, because we're replacing an aortic valve, that mum will be in hospital for a week or 10 days. That's not necessary. We need families to understand we're not throwing people out of hospital. It's now considered pretty normal to go home within a couple of days of hospital. So we get the nurse coordinators involved talking to families. We try to keep the procedures to a minimum. We get people up and moving. And then this is where you guys come in. We want the patients to visit you early and make sure that you're happy that the patients have not been compromised by going home early. And these are the sort of things we would like you to think about. And this is my last slide. If you see a patient in the first week or so after a TAVI procedure, these are the things to inquire about, to know about. Do they have any bruising or pain at their access sites? We typically would use the femoral arteries to get access, so usually both sides. We'd like to know that they don't have any new conduction block. Often it's not uncommon to get a new left bundle branch block, and we don't pace that. But the discharge summary should show pretty clearly that they have a new left bundle that we're not unhappy about. But you do need still to make sure they're not having dizziness. We'd certainly want to hear about anybody who had any blackouts or evidence of a new conduction disturbance once they got home. Atrial fibrillation occurs sometimes, not very often. Sepsis occurs rarely, but we'd need to check the access sites, the urine if they were febrile, pacemaker site if they'd had a pacemaker. And we're always worried about the risk of sepsis causing infection of the valve or endocarditis. Most embolic complications occur during the procedure, but there are some that occur in the weeks afterwards. So there's always a small risk of thrombotic emboli from the leaflets of the valve. You can have strokes in that early period or systemic emboli. It's common or usual during a TAVI procedure to stop things that might cause conduction disturbance. So beta blockers, for example, digoxin, they would probably be held in the early period after a TAVI, and some of them may need to go back on that if they're sent home without those medications. Similarly, it's not uncommon to stop antihypertensives, and it would be very common to stop warfarin or NOACs, and they need to be reinstituted. So on the off chance that you've got someone who's come home in atrial fibrillation without their warfarin being restarted or their apixaban, you should contact us. There may be a reason for that, but it could be an oversight on our part. So we want people to go back on their medicines reasonably early afterwards, there's sometimes a good reason for holding them. We talked, I think, in the first presentation about dual antiplatelet therapy and the normal protocols, typically 3 months of aspirin and Plavix and then one or other alone. But if they're already anticoagulated, it might be just the anticoagulant or an anticoagulant plus one antiplatelet drug. It's important to remember for these patients that endocarditis prophylaxis is paramount. So if you have someone, particularly a younger patient who's still got all their teeth going to the dentist, that they should be treated with endocarditis prophylaxis. And you will see eventually degeneration of these prostheses, and that will be either aortic regurgitation or a stenotic bioprosthesis. So if you can keep alert to those sort of things, particularly in the patients who do go home early, we'll be watching them pretty carefully in the first 48 hours, 24, 48 hours, but it is possible that some of them can develop problems beyond that once they've gone home. I'll leave it there and see if you have any other questions. We have a few minutes left, I think, just for general questions.
Yep, a few questions have come through. So the first is, as a GP, should I do an ECG when I see a patient post-op as a routine to assess any heart block or rhythm issues?
Yeah, good question. I think yes is the answer. We will do, so if we've got any concern about a patient, we'll do daily ECGs. So every now and then you see someone who's got a new left bundle branch block after their TAVI, we might keep them for an extra day or two. And if we see an increasing degree of left bundle branch block or first degree AV block, for example, then we might think about the need for pacing at that point. So I think as a baseline, it's good if you see the patients a week or two after the TAVI procedure, just to document what make sure they have no additional or new conduction disturbance from what we described when they left hospital.
Great. The next question is, what is the cost of the TAVI procedure and is it offered to public hospital patients?
Right, well, that's a good one. So the current state of play is that TAVI is reimbursed for private hospital patients if they are considered high risk for surgery. Now, Medicare is not caught up with the literature. We now have good quality, randomized, controlled literature that would suggest that certainly intermediate risk and now even low risk patients do as well as or even better than surgical patients, surgical AVR. So there are applications in with Medicare for reimbursement for the intermediate and the low risk patients, but that's not come through yet. So if you have someone who is 70 years old who has no good reason not to have surgery, they might ask for TAVI, but they won't get reimbursed for it. They can pay for it themselves in the private system. The TAVI valve typically costs about $25,000, and a TAVI procedure could cost anything above and beyond that, from $20,000 to $40,000, depending on whether they have to go to ICU or need a pacemaker or have other complications. So we don't encourage people to pay for it themselves, but we have had people who do not want to have surgery and they would pay for it. In the public hospital system, we are governed by much the same rules as the reimbursed patient indication. So we are expected to treat patients who are high-risk patients and not the low to intermediate risk. But it's a moving target. Applications are in the next year or two. There will be reimbursement, I'm sure, for lower risk patients.
Great. And the next question is, how many patients need revision surgery for TAVI and Mitraclip?
You mean someone who's had the procedure and then needs to have that treated surgically? Well, we've had I don't recall having had anybody have to have a TAVI procedure retreated because the TAVI has degenerated. So we've been doing this for 10 or 12 years. There may be the odd one or two who's ultimately had to be treated, but very, very few. We have had one or two patients, perhaps a few more than that, who have not got a good result in the early period. So one of the problems in the early phase of this was that the core valve, as it was called back then, was not repositionable. So we had to accept what we got, and sometimes those valves ended up too high or too low, and we did send them back, send them off to theatre to have the valve removed and treated surgically. But since we've been able to use a repositionable valve, if the valve is not in an optimal position when we've deployed it the first time, we can recapture it and redeploy it in a higher position or a lower position. And that's avoided the need for anything surgical for for very many years. So we're still expecting that in due course we'll see some of these valves degenerate, but most of the people who were treated earlier were not surgical candidates anyway, so they probably wouldn't be able to have surgery for that. Mitraclip's a slightly different procedure. We do not get a perfect result every time. About 25% of Mitraclips still have moderate to severe MR at 6 months, and some of those we've taken out and replaced surgically. So it's more likely with Mitraclip than TAVI.
Great, thank you. So now we might move to the pre-submitted questions, which could be relevant to either or both of you. So I'll read out the first one. So the first one is, what is the role of a CT angiogram in primary prevention?
Is that for?
Yeah.
Okay. Look, I think a CT angiogram has really come in and replaced the pathway of looking after patients at increased cardiovascular risk. Our old-fashioned way of looking at patients was to bring them in, and if they had some degree of risk, we would submit or subject them to a stress echo or a stress test. The problem with this sort of treatment pathway is often, of course, how often do you do a stress test, and what does it mean? If someone has a normal stress test, how do we know what targets we should be setting their lipids at? How do we know how tightly their blood pressure needs to be controlled? And it does make, reassuring the patients in the future difficult. We've all seen patients who've had a negative stress test and then had an infarct in a certain time period afterwards. I think one thing that CT has really revolutionized is to be able to look at the images, and in patients where they've got an elevated calcium score and some plaque in their arteries, actually say to the patient, and this is why we're giving you your statin, this is why we're treating your blood pressure, this is why you need to improve your lifestyle factors. And there's a very good study called the Scott Heart study, which actually demonstrated that using a CT scan early in the disease process improved compliance and actually improved the mortality in patients longer term, because the patients were much more likely to adhere to their medications. And of course, occasionally we find patients who have a CT scan or a CTCA that we discover terrible coronary disease that was sort of waiting to cause big problems, and then we can do something about it.
Yeah, I might just amplify some of those things. I would agree entirely. And one of the real values of it, I think, is that we used to talk about primary prevention and secondary prevention. And the data for treating, for example, high cholesterol levels for secondary prevention are extraordinarily strong. There's barely a trial that has not shown a benefit in terms of stroke risk or heart attack risk. For someone who's had a stent or a bypass or a stroke or an infarct. So that's a no-brainer. There just is no discussion about the need for statin therapy and treating cholesterol levels. But it's very difficult sometimes to know whether a cholesterol level of 6.5 in a 50-year-old should be treated or not. And primary prevention data are not as strong for statins or some of the risk factors generally. So what the CT has allowed us to do is to help stratify those patients who are primary prevention effectively, but in fact they're really secondary prevention because they've already got established disease documented by CT angiography. And then, as far as I'm concerned, it's a no-brainer. They should be treated vigorously and getting the cholesterol under good control and all of the other risk factors to minimize, to prevent that first episode.
Great, thank you. Yeah.
Can I just add one more point, is that sometimes we're seeing patients coming back and having repeat CT scans either sent from another specialist or from primary care, and they get quite fixated on the fact that their calcium score has gone up over the 2 years from 500 to 900. And really, I don't think that the CT scan has as much value in being repeated again and again. There's obviously a radiation increment that goes with that. But, you know, the calcium score reflects a number of things, including, you know, the transformation of soft plaques into hard plaques. And, you know, repeating the calcium score actually doesn't give you any new information. So I think if you've already established the patient has coronary atheroma, then you aggressively treat with the lipids, and then particularly if they've got mild or moderate atheroma, then there is a role for regular stress testing, but not obviously in somebody who's got a normal CT.
Great. So the next question is, how low can LDL go to as per target? Is there a suicidal risk if it is too low?
Suicidal risk, that's a good question. Okay, so this is an important one, and this is something we see all the time. Somebody has been on a statin, their LDL is 1.3, and his general practitioner says, this is too low, there's a risk of whatever the perceived risk is, and therefore we'll cut back on your statin. I don't believe anymore that that is the story. We have now seen data from the new cholesterol-lowering medications, the PCSK9 inhibitors, that have been able to, they are highly effective, particularly in combination with statin therapy. And in those trials, they have documented LDL levels in the low, you know, 0.2, 0.3, well less than 1. And there is no detriment. There is no increase in mortality, no suicidal risk. You don't get brain meltdown because your cholesterol's too low. The lower the better. And there is a continuing benefit in terms of stroke risk and infarct risk in going from an LDL to 2, down to 1, down to 0.5, and down to 0.2 still. So I am firmly of the belief that in the next few years, we will see the target LDL shifting way down, and we will all be expected to get our patients' LDL down below 1 ultimately, because we will have therapies that do that effectively. And I don't think you should be worried about any risk of suicide or other complications.
Great. The next question is, what has been the success with restenting blocked stents?
That's a difficult question because it encompasses so many different situations. But I think particularly if somebody's had an older stent, a bare metal stent, or one of the very old first generation drug-eluting stents, it is definitely a reasonable strategy to consider restenting that. Alternative strategies and restenting it with a third generation or current generation drug-eluting stent, because obviously the option, if we're not restenting, is to send the patient for bypass surgery. Now, you don't lose anything in restenting and finding that that strategy fails. There is definitely a fractionally increased risk of restenosis if you're stenting within a restenosed stent. But, you know, I think for the most part, if it's the first time and if they've had the stent for a long time, it's still a reasonable thing to do. There's a lot of work around on drug-coated balloons, and there was some excitement in the cardiology community about them, although I'm still a little reserved on how effective they actually are. And I think, David, you probably feel a little bit the same, in that a drug-coated balloon we inflate within the stent, and the idea is that the paclitaxel in the drug or in the balloon will actually treat the plaque and stop the restenosis process. But, you know, a lot of the time I think you actually need a scaffold as well, and so we still get very good results stenting within restenosed stents.
Yeah, I'd agree. I think, you know, I grew up in the very first days of stents, and the restenosis rate, you know, was 30 or 40%, and the re-intervention rate was high in the first 6 months, and the results of that were poor. And we ended up having patients having multiple restents and multiple re-angioplasties, and eventually we gave up and sent them to surgery. We just don't see that anymore. We rarely see a recurrence. The stents that we use at the moment are exceptional. The restenosis risk is small. If it does occur, particularly if it doesn't occur early, then I think restenting is a very good option. But there is a limit. You can't keep restenting a recurrent lesion. Eventually, you have to give up and say the surgeons win this one.
Mm-hmm.
The next question is stenting versus thrombolysis. Which is being practiced currently, and is the outcome similar?
Well, so I mean, I think really in the 21st century, thrombolysis is reserved for rural areas or areas where you don't have immediate access to a cath lab. We don't use thrombolysis here routinely. I can't remember the last time we used it, simply because all of the evidence shows that primary percutaneous intervention, i.e. if someone's coming in with an ST elevation MI, they are better off being brought directly to a cath lab, and that's actually very, very strong data. There are lots of places in Australia clearly where you can't get that patient to a cath lab within a reasonable time frame, and thrombolysis is very effective and has still a value in those patients, but often those patients, or all of those patients, will still inevitably have to be taken to a cath lab to have their anatomy defined. So really the thrombolysis is only buying you time.
Yeah, we did have. Sorry, we just in this COVID period, we had to brush off the textbooks and start to think a little bit about what we would do in the event of an onslaught of patients with COVID-19. And there's certainly around the country been discussion about treating patients with lytics to minimise the exposure, mostly of staff, to the patient. And I never really thought that was the right approach. I don't think that was in the patient's best interests. And in fact, we couldn't find any lytics for a while. So we're still, even in the COVID times, would take people to the cath lab rather than give them thrombolytic therapy. Thrombolysis is used for brain infarcts, for strokes in some cases, and it's good, better than nothing there. But even there, I think if you had a choice, you'd have someone fish out do a thrombectomy and fish out the clot rather than treat it with thrombolytic therapy.
Great. The next question is, when does one need CABG versus stenting?
Oh,
some time.
Yes, that's a very, very tricky question. I can answer it honestly and fairly briefly, I guess. I've been doing this for a long time, and most of my career I've tried to do the surgeons out of a job. I think we're doing a pretty good job of that with the TAVIs. Very soon, I think isolated aortic valve disease will not be treated surgically. It'll be treated by TAVI. Similarly, most straightforward coronary disease can be and should be treated initially with coronary stenting. The ones we send to surgery are particularly those that have extensive diffuse disease, particularly proximal 3-vessel disease, chronic total occlusions where it can be difficult to open an artery and put a stent in it. Diabetics are perhaps better treated surgically because the recurrence rate, the restenosis rate, is a little bit higher, but their outcomes of surgery are not as good as non-diabetics either. So there are all sorts of things, and of course, presence or absence of other valve disease that might persuade you to do a valve and bypasses rather than coronary stenting. So there's a lot of stuff that we do now that might have been done once upon a time by surgery, but we still respect the surgeon's outcomes for proximal disease and particularly chronic total occlusions, I guess.
And I think particularly on that note, anything that doesn't involve the LAD, when all the trials are done in surgery, really it's the prognostic benefit comes from getting an arterial graft onto your LAD, so a Lima graft. And if you've got disease that is not involving the LAD, actually, there's no particular prognostic benefit in stents or surgery, and you would actually go on the anatomy. If it's very diffuse, you might consider bypass. If it's straightforward focal lesions, you would put stents in.
There's been a trial recently that's really thrown a cat among the pigeons with respect to left main disease. So left main's an interesting thing. When I was growing up, there was no question. It was left main disease meant bypass surgery, and that was end of discussion. No one would challenge that, because when we had treated left main disease with bare metal stents or balloon angioplasty alone, the mortality rate from restenosis was pretty high. So we learned the hard way that was a bad thing to do. But as drug-eluting stents became more prominent and the trials started to tease out whether isolated left main disease could be treated with stents or should always go to surgery, it looked pretty much like stenting was a good choice. And in fact, the guidelines in Europe and to a lesser extent in the US changed the recommendations to a pretty strong recommendation for stenting left main coronary disease rather than sending all of them to bypass surgery. There has been a trial recently that's hit the press, and there's a lot of argument about what it means, and a lot of it relates to definitions of endpoints. I don't think it really changes it. For my money, if you have isolated left main disease and something that can be stented, it should be.
Great. The last question we have for the evening is, what is the SGLT2 role in CVS outcomes in non-diabetic patients?
I've been stitched up because that's a hard question. A hard question for an interventionalist. But look, I think, you know, we're seeing there's a very good paper in the JAMA suggesting obviously that SGLT2 inhibitors are of benefit in heart failure patients with diabetes, but also of potential benefit in patients without diabetes. They haven't been around a long time, but just anecdotally, I've a number of patients who've actually been on these drugs and I've had to back off. They've been stable with heart failure for some time. The endocrinologist or one of us has become involved and started them on one of these drugs, and actually we've had to back off on the furosemide or any maintenance diuretic because they definitely have a powerful diuretic effect. You know, I think there's still really only one good study suggesting the beneficial effect in non-diabetic patients. So I think more work is needed in that area. Of course, there are some risks of some unusual vascular complications with toes dropping off, and also recurrent urinary tract infections from the glucose effect in the urine. But you know, I think there's going to be a very an explosion of these drugs in the treatment of heart failure patients.